Okay, why don't we get started here? And hello, um, this is Elliot Fishman, and welcome to our latest CT is Us weekly Facebook Live. And I hope everybody is doing well. It's only 1 week to RSNA, so things are getting closer to RSNA. And I don't know how many of you are going, but those of you who go, I hope you enjoy it. And so here, what I'm going to do is try to share with you some of the interesting cases. I mentioned it every Wednesday. I have a conference. I quiz the faculty. And these are some of the cases I showed yesterday. It's only a small sampling because we do a lot more cases than just this. So, and I'm looking, everything looks live and perfect. So here we go. Let's get started. So this is a patient with GI bleed. When you look at the images, the first thing you see are multiple vascular lesions in the liver. So I'm asking, why is there a GI bleed? Well, you see the vascular lesions in the liver. One of the key things to notice in this case is that the patient, you see part of the right kidney, but you notice the spleen is missing and the bowel is falling by the left renal fossa. That's a very, very important hint for you. And then you look at the next image and there's a mass in the region of the duodenum. You could see it on the axial and coronal views. And then as you go a little bit further, you can see again the mass a little bit better. It's a vascular tumor. There's some nodes in the mesentery. And you can see the right kidney, but you recognize that the left kidney is missing. Here's a coronal view. You see the liver lesions. You see the duodenal lesion. So what are we dealing with? Well, what gives you vascular duodenal lesions? Well, one thing you can say is a neuroendocrine tumor. Small GIST tumors can do it. But the hint I gave you is you're missing the left kidney. So what gives you vascular lesions in the liver and in the bowel, and it could be in the pancreas as well? Well, the thing that does that is going to be metastatic renal cell carcinoma. Here's some of the coronal views with cinematic rendering, nicely showing you the tumor, nicely showing you the whole abdomen, and the answer here is metastatic renal cell carcinoma to bowel and to liver. So a really nice example. So if you do see lesions in the small bowel, the vascular, think about METs, think about neuroendocrine tumor, think about GIST tumors, liver lesions like that. You can go through a range of differentials as well, but always look for the kidneys. The same thing is true when we see METs to the pancreas or masses in the pancreas. Look for that. So that works out very nicely. And if people have comments, by the way, one of the things we do a little bit differently now, Lily has been sharing these cases with you in advance for a couple days, so hopefully some of you have been able to look at it before I've gone through the answer. Okay, next case. Patient has an acute abdomen. What's going on? Well, you see air within, first you'd say maybe it's biliary ducts, but then you recognize and you're looking at air within the venous structures in the liver. And then when you scan downward, you note that the patient has air within the bowel wall, pneumatosis in the small bowel. When you see air in the bowel wall, there are reasons you can have it that aren't worrisome, sometimes a procedure or a biopsy, but you're always going to have to worry about ischemic bowel. When you see air within the bowel wall and you see air within venous structures, and here's a really impressive example through the pelvis where there's extensive pneumatosis, what you have to worry about is ischemic bowel. And in fact, once you have air in the portal venous system and air in the veins, you can see some of the mesenteric veins with air, then not only do you have ischemic bowel, but it's probably also infarcted, and this patient's survival is really going to be a risk. So this is this is the worst thing you can find in terms of ischemic bowel and infarction. And that's what it was. Patient had gangrenous bowel at time of surgery. Now let me say hi. So if you have any questions, you can mark them down. And I see I'm saying hello to John Biacchino. Hey John, John's from home today, which means he's not working. Hope he's having a good time there. Okay, and then so let's keep going on to the next case. This is a patient with fever, and what you see in this case is you see multiple masses in the root of the mesentery. They're kind of low density. It looks like nodes, and then you ask yourself what kind of nodes can you possibly see in the mesentery that are low density? Well, you can see things like big nodes from testicular tumor. Whipple's disease also can give you low density nodes. But when you see low density nodes in the mesentery, and let's keep looking, You can see those mesenteric nodes very nicely. Cystic low density, it's a classic thing. It's not going to be lymphoma. Lymphoma, typically it's solid unless you've been treated. This patient hasn't been treated. And you can see the mass in the root of the mesentery. So what you're dealing with is usually an infectious etiology. And typically it's MAI infection. An MAI infection, you can see some of the nice images with cinematic where the vessels are narrowed, the branches off the SMV and SMA are narrowed. You appreciate the masses. So you got to be thinking about infection, and MAI is the classic thing that gives you cystic mesenteric nodes. It doesn't give you desmoplastic reaction like with carcinoid, and carcinoids typically are vascular. So that makes all the difference in the world at reaching the right diagnosis. Okay, another case. Abdominal pain. What you see very obviously is a mass in the body of the pancreas. It's low density, but it's not cystic. There's a calcification present. There's no dilated pancreatic duct. Here's a few more views of that. Well, age would be helpful. If I told you it was a 45-year-old female, then you would think about a mucinous cystic neoplasm, which often is in the body of the pancreas, though usually cystic, but when there's dysplasia, you can have solid components, and typically does not obstruct the patient's pancreatic duct. Here it is again. The mesenteric vessels, the GDA, all look good. Here's the cinematic rendering of that. But if I would have told you this person was a teenager, then you would say, aha, low density mass, no dilated duct, faint calcification. That's a very good description for a tumor commonly in women, age teenage to 20s, and that's a SPEN tumor. And SPEN tumors are really nice. They're low density. The good news is you recognize them and you resect them as a 90% plus 5-year survival is really a 90+% cure. Every once in a while, less than 10%, they can be aggressive or they can recur. Most of the time, you'll cure the patient. Now, another patient. I would say this patient was referred to a pancreas clinic. What you see is a mass that at first looks like it's coming off the pancreas, but it's really between the pancreas and the stomach. And the more you look at it, could this be coming off the pancreas? Well, lymphoepithelial cysts come off the pancreas, seem to be exophytic to it, but this is not cystic, this is solid. One of the things we've learned, and I've showed you many cases of gastric GIST tumors come off the stomach, but they grow exophytic and almost look like they're pushing on the stomach. You can see it very nicely here along the patient's lesser curvature of the stomach. There's some enhancement present, and this is a classic appearance. Again, think about it. It's not an adenocarcinoma, it's not going to be lymphoma. Gastric GIST tumors are the things that come off the stomach, can push on pancreas or spleen or kidney even. They tend to be large. They're exophytic, nicely shown here in cinematic. Very classic for a gastric GIST tumor. A really, really nice example. And hopefully you do appreciate that as you look at it as being a really great case that you can be looking at. So it's a case I really do like. Another example, abdominal distension. Wow, look at this cystic mass. Now I will admit, I don't know where this is coming from if I look at these few images. It could be the pancreas, it could be a mesenteric cyst, it could be coming out of the patient's pelvis like an ovarian cystic tumor, it could be a large retroperitoneal sarcoma cystic type tumor. If I told you this was pancreas, then you start looking and on the coronal view you see some septations. What gives you a large cystic mass with septations? Now obviously large cystic masses, you can think about serous cystadenomas, they can be very large. They have septations, mainly would look like almost like daughter cysts, but when you start seeing thin septations mid-body, particularly in a middle-aged female, you got to be thinking about mucinous cystic neoplasms, commonly referred to MCNs. All MCNs are going to be resected regardless of size because they can be considered pre-malignant. They often get high-grade dysplasias eventually. Look at the beauty on the cinematic, how it's compressing the aorta and the left renal vein, displacing arterial structures, very nicely shown. A really nice example of a complex cystic mass with septations, and that's a mucinous cystic neoplasm. Again, oligocystic serous cystadenoma is a consideration, perhaps. A pseudocystic patient of pancreatitis, I've seen large pseudocysts. And again, I'm not showing you the entire study, so theoretically it could have come out of the pelvis. So I'm not perfect but with that one for you guys, but MCN is the right answer. Now I'm showing you another case. Look at this one, another big mass. This looks kind of cystic with maybe some solid component, has calcification. You don't see the patient's kidney, okay, the left kidney. So you worry, is this just like the last case at MCN? Could this be a pseudocyst from pancreatitis? Could this be a cystic mass that bled? What could this be? There's a whole bunch of stranding to the left upper quadrant. This ended up being a complex case. Again, the differential diagnosis, I thought this was a renal mass that probably bled into itself. Remember, angiomyolipomas could bleed into themselves, renal cell carcinomas, patients with AV malformations, patients with renal artery aneurysms can all have bleeding. But what this was, you can see some more views of it. When this was resected, it was just a large hematoma simulating a renal mass. There's a little rim of kidney present, but this was just a large hematoma. There was no evidence of active bleed, and there was no explanation why the patient bled. Remember, if a big mass bleeds, sometimes you can hide the tumor. That's true in the liver, that's true in the pancreas, that's true in the spleen as well. Another case, patient short of breath, and I showed you this case as a little bit of a trick in the sense that what's going on here, you see lots of collaterals posteriorly, and there you see the collaterals again. What are we dealing with here? Well, we're dealing with coarctation of the aorta. Just a really nice example of coarctation. Look at all of those collateral vessels, really nicely seen in that example of coarctation of the aorta. So a really great case. This was interesting. This patient came in short of breath. You know, most of the time coarctation of the aorta is something you detect when the patient's very young. This patient managed somehow to escape till they were in their 20s or so, and only then did they present. Okay, and again, the cinematic I love, showing you the dilated internal mammaries, the intercostals very nicely shown. Last case, left upper quadrant pain. Look at the spleen. The spleen is large, but look at its attenuation. It really isn't attenuating. It's not enhancing like you would expect it to look with a good injection. So what gives you this large spleen and multiple low density zones, and you can see it on the cinematic, the different cystic areas as well. Well, things that do this, you could say, well, could this be an abscess? It's possible, but the host spleen involved is unlikely. Could it be lymphoma, leukemia, the host spleen infiltrated? I couldn't argue against that. One of the appearances of the spleen with lymphoma can be diffuse infiltration or for its low CT attenuation. What else could it be? Well, what about infarction? Infarction is really good. The spleen often is low density, the entire amount. Infarction can be focal or diffuse. But this looks like the whole spleen is involved. When you're thinking about infarction, you're thinking about sickle cell. When you're thinking about sickle cell, another thing to think about is sequestration. Sequestration is when you have blood engorging the spleen. Splenic infarction and sequestration often occur together. It's not uncommon, particularly in patients with sickle thal variant. You can see thalassemia presenting with very large spleens, including sequestration. Again, a good example, large spleen, poor enhancement, looking like infarction or infiltration. You want to consider that possibility. So I think that's what I have for you today. I think that's about 8 really good cases. I hope you enjoyed them. I just want to say, if anyone has any questions, they can email me. We'll say hello to Carlos, who's from Lima, which is a lot further away than John, who's in Timonium is, which is about 15 miles as the crow flies. And you'd have a very tired crow if they flew all the way to Lima, but I guess it's doable. And I hope everyone enjoys the cases, and I hope to see you again all next week. And just as a reminder, because in the U.S., next Thursday, which is today, a week from today, is the Thanksgiving holiday. I am going to do the Facebook Live on Tuesday. So it'll be Tuesday at 12 noon, roughly, or 12:30, rather than next Thursday. So I wish everybody a happy Thanksgiving, a happy pre-Thanksgiving. happy RSNA, happy New Year if I don't see you. Um, and the other thing I can tell you is if you want to laugh and you have HBO Max or whatever HBO is, I have something at home. I don't know what it is. It's not very max. I watch TV a half an hour a week for 10 weeks a year, and that's when Larry David is on. So Larry David, the new show, Curb Your Enthusiasm, is on. We get no royalties for advertising. We're not advertising the show. It's never in good taste, but it is funny, and it really looks at humanity. And what they did this year is they did the show as if COVID is over. So I'm hoping that Larry's right. He did not want to do anything with COVID because COVID is not funny and never will be. So I'm hoping that all of us are going to soon be in Larry David's world where it's post-COVID. So with that, I thank everybody for their attention and have a great day.